So I think we'll go ahead and get started since we're right at the 10 a.m. mark. Welcome everyone, and thanks for joining our TB 101 series, which starts today. So we've sort of been hearing the need for a lot of basic TB training, or just covering more fundamental concepts in TB for a lot of new staff who are, starting out in public health. So the objective is to sort of build off of background information that somebody would have read, say, in the CDC self-study modules or the core curriculum. So we're hoping to also provide the opportunity for you as the attendees to ask questions live from our TB experts who will be presenting. So the sessions will run every Friday, starting today, and it'll run through September 15th. The outline of topics is on our website, so you can go ahead and access that through our training calendar online, and then click on TB 101, and it'll bring you to a page that has each of the session dates as well as the topics, and we're still in the process of confirming speakers. So we actually held this session for the first time, this series in 2021, and it was very well attended. So we are planning to record each of the sessions with the goal of posting them online afterward. Certainly, we recommend that you join the entire series. Just the complexity of topics sort of build off of each other weekly. We're also hoping to, any remaining questions, maybe after you've had some time to process what's being presented today, and you go back and you're like, I didn't really understand that, or I have additional questions. We'll have some time at the beginning of each subsequent session to address those questions as sort of a little bit of a review each week, but certainly we'll be sending out an evaluation after today. If you have additional questions, you can put them in the evaluation. And if it's something that you would like a direct response back to your question, please feel free to include your email address, and we can be in touch with the response to your question. So I think with that, we'll go ahead and get started. If at the end of the series, we might also send out an evaluation if there are other topics that are that you think would be helpful to cover and say a TB 101, we'd be happy to include those the next time around. And we also recognize that there's a need for sort of more advanced training as well for staff who've been working in TB for a while. And so we're hoping in the future to also offer a TB 201. Which will be at a little bit of a higher level. So I'll go ahead and get started to introduce our speaker. Will be Dr. Farah Parvez, and Dr. Parvez is the Director of Training and Outreach at the New York City Department of Health and Mental Hygiene Bureau of TB Control. And she's also a Field Medical Officer at the CDC Division of TB Elimination. And Dr. Parvez is also a captain in the U.S. Public Health Service and has served with pride and distinction since 1998. So we're really excited to have her present today on our first session, which will be addressing transmission and pathogenesis of TB. And Farah, I'll turn it over to you now.
Great. Thank you so much, Anita. I really appreciate that nice introduction. I'd like to start by just welcoming everyone to this session. It's a pleasure for me to be here, and it's wonderful to see right now 156 people online that are interested in tuberculosis. We're thrilled to have you join us, and we do hope that you'll continue throughout the summer series. So today I'm going to be providing sort of a high-level overview of transmission and pathogenesis of tuberculosis. As Anita mentioned, throughout the summer series, you will be going into more of these concepts in depth over time, but today we're here to just sort of provide a large overview. Next slide. So the objectives for today's presentation are to briefly describe sort of the history of tuberculosis, to explain how TB is spread, to explain the difference between latent TB infection and active TB disease, and to explain how these two states really develop once someone has been exposed to the tuberculosis bacteria, and then to describe the classification system for TB that public health programs use. And I'll just mention here that I do not have any financial disclosures. Next slide. Next slide. Okay, so as probably most of you know, tuberculosis, or TB, has affected humankind for millennia. The original mycobacterium is believed to have originated, tens of millions of years ago. But it was first really sort of identified in mummies about 9,000 years ago. So we know that this is a bacteria that is resilient. It has survived over centuries. And, in the 1800s, 1700s, it was historically sort of known as consumption or wasting disease or the white plague because of the symptoms and sort of the signs that someone would exhibit if they had tuberculosis. So they would have unintended weight loss. They would be very pale from anemia and just feeling fatigued. And so, hence these sort of descriptions for tuberculosis. But, it's important to remember that prior to the COVID-19 pandemic, tuberculosis was the leading infectious disease killer worldwide. And, more than HIV and measles, chickenpox, any other condition you can think of combined, tuberculosis is the leading infectious disease killer. So every year, approximately 10 million people develop TB. And of those, about 1.6 million die from their TB every year. And when we look at pediatric TB globally, about 1 million children develop TB disease, and nearly 250,000 die every year. And so this is something that has tremendous morbidity and mortality worldwide. Next slide. So until the mid-1800s, many believed that TB was actually hereditary. And the reason they thought that was because, there would be generations of families that were impacted by tuberculosis. So there was this belief that it was sort of a genetic defect that led people to have TB. But in 1865, Jean-Antoine Villemin, who was a French physician and a military physician, showed that TB was actually contagious. He sort of noticed that, military personnel who lived in barracks were more likely to come down with TB versus military staff that were in the field, out in the open. He did some laboratory-based studies involving rats where he inoculated them with the material, sort of the pus and the purulent material from TB cavities of someone who had died from TB. And he inoculated that into rabbits and then found at autopsy that those rabbits also had TB disease. But it wasn't until 1882 when Robert Koch, a German physician, discovered that TB is a bacteria, and that this particular bacteria causes what we know to be tuberculosis. Next slide. And so he, on March 24th in 1882, announced to the German Physiological Society his finding that Mycobacterium tuberculosis is a bacteria that causes tuberculosis and the symptoms associated with it. And this was truly revolutionary in the sense that prior to this, we were thinking that it was genetic. We were using sanatoriums as a treatment mechanism for people with TB. And the announcement that this was a bacteria really allowed us to think differently about what could treat it and cure it. Next slide. So before we had tuberculosis antibiotics, many patients were actually sent to sanatoriums worldwide. And so, I think in Europe was the first place where a sanatorium was developed. And the idea was that you could have patients who are able to rest and be out in the fresh air, have a good diet, and allow themselves to really heal. And unfortunately, the sanatoriums were available to people who had money, who had privilege, who were able to do this, take time away from their employment and their families and go off and sort of rest. But patients who could not afford sanatoriums, unfortunately, often died at home. Next slide. And so this is a brief timeline of sort of some of the major events in the history of TB, and this is by no means comprehensive, but essentially, as I mentioned, in 1865, Jean-Antoine Villemain showed that TB is contagious. Shortly thereafter, Robert Koch discovers that it's actually a bacteria that causes the TB disease. And around that time, in New York, in Saranac Lake, Edward Livingston Trudeau established our first sanatorium in the United States. And then it was a while later, it took a little while, but in 1942, 1943, streptomycin was identified as a drug that could treat TB. And shortly thereafter, isoniazid and salicylic acid was discovered as well as two treatments that could also treat TB. And that really changed the entire way we thought about how to manage and treat TB. And those three drugs were so effective that by the mid-70s, 1970s, most TB sanatoriums in the United States had closed. We realized that we could actually effectively, safely treat patients at home. They didn't have to go, miles away from their family and friends and employment. So that was a huge change for us. And then by the mid-80s, as I'll show a little bit later, there was an unexpected rise in TB cases. So even though we had gotten to this point where we felt like we could manage TB, there was a change in the epidemiology of TB that led to a significant explosion of cases. Next slide. So this TB resurgence in the mid-1980s is believed to have been caused by what we sort of call the 5 I's. So the first I is infrastructure. There was essentially, as we started to get TB under control, TB started to fall down in people's, sort of consciousness, and we started losing funding for public health activities related to TB. And, this is a cyclical cycle, as I'll show later, that, as we are able to better manage and control TB cases, funding goes down, and then we see a resurgence. So we certainly saw this in the mid-80s. And then, inappropriate TB care, there may have been sort of poor treatment practices, maybe not as much attention to treatment adherence and completion, inappropriate treatment regimens. We really didn't have the vast array of sort of drug susceptibility tests and results that we do now. Immunosuppression was a huge component in the resurgence, along with substance use and homelessness in certain areas, particularly the HIV/AIDS epidemic, widespread immunosuppression, led to an increase in TB cases as well. The fourth I is infection control. So poor infection control practices in hospitals and congregate settings, such as shelters or correctional settings, led to TB transmission. We had an increase in multi-drug resistant TB, which is tuberculosis that is resistant to two of our most important TB drugs, isoniazid and rifamycins. And then immigration is the fifth I, changing immigration patterns in the 1970s and 80s, with more immigration from countries where there is already a high prevalence of TB. So these 5 factors are believed to have really led to the sort of explosion in TB cases in the mid-90s in the US. Next slide. And so when we look at our sort of graph of reported TB cases in the United States from the mid-1980s on to 2020, what we see is that once we saw this increase in TB cases in the 80s and 90s, we started to receive more governmental funding for TB control programs. That started about 1992 when we had over 26,000 cases of TB in the US. That gave us an incident rate of 10.4 per 100,000. Just in contrast, now in about 2020, our incidence rate was actually 2.2 per 100,000. So in the early 90s, the TB incidence rate was much higher. There was a lot more TB transmission in the US. And so with this influx of government funding, TB programs around the country were able to start building infrastructure, were able to start doing case management and contact investigations, and make sure that people were starting the right treatment and able to complete treatment. And so we saw our number of TB cases decline from 1993 to about 2014. And around 2014, we noticed sort of a generalized plateau of TB cases. So cases weren't going up, they weren't necessarily going down at the rate that we wanted. We sort of were able to maintain some kind of a homeostasis. And then, as you all know, during the COVID pandemic, many TB staff were redirected to COVID response efforts. Funding that might have been used for TB was now being redirected towards COVID. And staff were resigning, retiring. And so this, for a variety of reasons, including sort of the COVID lockdown and people maybe not accessing healthcare in a timely enough fashion, it led to sort of what we saw as a decrease in the number of reported TB cases. But as you know, what we're seeing now is sort of a return to pre-pandemic baseline levels of TB. And what we're fully expecting is for TB to once again reign as sort of the leading infectious disease killer worldwide at some point. So I think the most important thing that this slide shows is that, it's essential for those of us that do TB work to always keep our eye on prevention and control efforts, regardless of what's sort of going around us. Next slide. So this is an important concept that was really designed and talked about by Dr. Lee Reichman of the Global TB Institute. He first described what he calls the U-shaped curve of concern. And so essentially, this is just a documented phenomenon that we've certainly experienced in TB many times, that as we have more funding, we're able to build public health infrastructure and capacity, we see that we're able to adequately control TB, we're able to prevent transmission. And so then our TB incidence rate goes down and over time. And then once people see that we're maintaining TB rates, we're preventing transmission, our TB case numbers are low, that funding gets taken away. It gets redirected to other either infectious diseases or chronic diseases or, emerging diseases. And then once that funding, that capacity, that infrastructure is gone, then again, of course, we start to see TB disease rates go up. And so right now we're at a point where we've seen that a lot of our resources, staff, funding, have been redirected towards COVID and then monkeypox. Now they're being redirected towards maybe the asylum seeker response or the humanitarian parole program response. And we're starting to see our TB case rates go up. And so it's important for all of us in the TB prevention world to be mindful of this phenomenon and to be careful to try to maintain our TB infrastructure and resources as best as we can. Next slide. So now we're going to pivot to talk a little bit about TB transmission. How is TB transmitted from person to person? I think most of us have seen this picture on the left in some capacity. This is really illustrating that when somebody sneezes or coughs, just the sheer number and volume of aerosolized droplets that can be expelled into the air. And these droplets will contain, in our case, the TB bacteria. And so the figure on the right shows how if somebody coughs because they have tuberculosis, someone else just will be able to breathe in those infected droplet nuclei and then become infected themselves. Next slide. So when we talk about Mycobacterium tuberculosis, we're talking about actually a grouping or a complex of bacteria that fall under this umbrella of Mycobacterium tuberculosis. So the majority of TB cases in the US are caused by Mycobacterium tuberculosis, or MTB. And this complex is made up of, these other mycobacteria that fall within this family, but the majority of them, of what we call TB, is actually by the M. tuberculosis bacteria. And there's another one that probably most of us have heard of, Mycobacterium avium complex. This is a bacteria that causes a different constellation of symptoms, and it's not what we call TB. So from this point forward, when I'm talking about MTB or Mycobacterium tuberculosis, it's really going to be this particular strain, Mycobacterium tuberculosis. Next slide. And so we can talk about TB being spread from person to person. And this is similar, if we're trying to explain it to a patient, this is similar to what we saw with COVID, that somebody could have the virus, that causes COVID infection. They can cough, sneeze, expel these aerosolized droplets in the air. Somebody else can breathe that in and also become infected with COVID. Sometimes you don't know where you got the infection, and sometimes it might be clear to you that you were around somebody else who had it. And so it's similar with tuberculosis. The TB bacteria is basically carried within these airborne particles, what we call droplet nuclei. And so these are water droplets that contain the TB bacteria in them. And these droplet nuclei are extremely small. They're 1 to 5 microns in size. And so they're quite small, and they can remain airborne for several hours at a time. So if you have someone with active TB that is in an enclosed space, they're coughing, those droplet nuclei can remain suspended in the air for several hours. And so if somebody else comes into that room and breathes in that air, there's a theoretical risk that they could become infected as well. And so if these droplets, land on a surface like a table, a desk, a chair, and somebody touches that, that's not going to lead to TB transmission. So transmission is not by surface contact, it's by breathing. So if you have a TB patient that's coughing, speaking, singing, even potentially laughing, these droplet nuclei can be expelled into the air. And so, the figure on the bottom is just showing someone with infection, TB disease in their lungs. And then when they're coughing, they're expelling these droplet nuclei. And then the figure in blue is breathing in those infected nuclei particles, which is going to be breathed into their lungs and set up an infection. Next slide. So, what is the probability that TB is going to be transmitted? There are several factors that really go into this, whether or not someone is going to be able to transmit their TB and someone else is going to be infected. So not everybody who is exposed to a person with TB disease is going to become infected. We're looking at the infectiousness of the person who has the TB disease. So if they don't have a lot of TB bacteria in their body, if it's early on in their disease process, maybe the number of bacteria that they expel into the air when they cough is not that high. It's a low amount, or what we call pauci bacillary. So often children who might have TB disease, when they're coughing, they're less likely to expel a lot of TB bacteria in the air. So a child is less likely to infect, let's say, an adult. We also look at the environmental factors. So, where was that TB, the person who has TB disease? Are they in an enclosed space? Are they out in the open? Is it a microbiology lab where they're dealing with TB specimens all the time. We're looking at all of those various factors to determine what is the likelihood of exposure. So when we go to do a contact investigation at a school, at a house, at a workplace, these are the types of factors we're looking at. And we're looking at, for the contacts, the people who were exposed to the person with TB disease, what was the proximity to the person with TB disease? How often were they next to that person? For how many hours at a time? So for example, if you're on a subway car and somebody has TB disease and they're coughing, but you're in the car with them for 10, 15 minutes, the likelihood of infection from that exposure is actually quite low. But if you're, a household contact and you're sharing the same bedroom, living room, kitchen, and you're around that person for obviously hours, days, weeks at a time, the likelihood of that exposure is much higher. And then it also relates to the susceptibility or the immune status of the person who's exposed. So if somebody is an otherwise healthy person, they're not taking any immunosuppressive medication, they don't have immunosuppression themselves, then, maybe their immune system is going to be better able to fend off TB infection or TB disease versus somebody who maybe has poorly controlled diabetes, who has cancer, who's on immunosuppressive therapy for bad psoriasis or other dermatologic conditions. That person's immune system may be a little bit more vulnerable. So exposure to somebody with active TB disease could lead to infection or TB disease. And so as we mentioned before, TB disease can be transmitted from children, though it's a lot less likely. Children seem to have more paucibacillary or, a low TB bacterial load, and they often don't cough with enough force to necessarily expel a lot of droplet nuclei into the air. But the best way to potentially stop TB transmission is first and foremost to identify it early. So to think TB, if somebody has, relevant symptoms of fever, cough, chills, weight loss, night sweats, to identify and think TB first, and then to quickly isolate that person from other susceptible persons, and then to provide treatment to that the person with TB disease as quickly as possible. And this is something we can talk about a little bit later, but what we're learning through our clinical experience, through studies that are being done, is that once a person with TB disease gets on effective TB treatment, their infectiousness goes down pretty quickly, certainly within a couple weeks, and it could be even sooner than that. And so the need for prolonged isolation, we no longer feel is necessary. And there's a lot of work that's being done to address this issue. Next slide. So now I'm going to talk a little bit more about the way that an infection or disease develops in the body once you've been exposed. Next slide. So I'm going to start with a quick overview. And again, don't worry that I'm going to get in too much into the immunology or microbiology of this. We're going to be kind of keeping things at a high level. But as you can see, the first figure with the healthy lungs on the right, that person has been exposed to someone with TB disease. And now they have breathed in these infected droplet nuclei. And so they breathed in the TB bacilli itself. The first line of defense in the lungs are what we call alveolar macrophages. These are cells that will basically engulf these droplet nuclei and engulf the bacteria within it. And this engulfment will result in the bacteria being limited in its ability to multiply and to spread throughout the body. Now, everything develops, everything is really dependent on the body's ability to kind of maintain this containment of the bacteria. So over the course of several weeks, the body is in this incredible limbo state of trying to recruit immune cells to help contain the TB bacteria. And that typically includes T cells and B cells. And then once that containment happens, it can go in a few different directions depending on the person's immune system. So this kind of containment we call a granuloma. that granuloma, through a variety of immune processes, could become calcified, and then that bacteria is basically killed and is no longer a threat to the body. Or it can begin to sort of rest in what we call a latent state. And I'm going to talk a little bit more about that in a minute. And then, or if the immune system is unable to contain this granuloma and immune state, the bacteria is just allowed to multiply and basically essentially break out of that granuloma and that containment. And then at that point, the bacteria has the ability to grow and spread and, cause symptoms and disease. Next slide. So we'll just kind of go through this in a little bit more of a stepwise fashion. So once someone inhales the infected droplet nuclei, it will go to the deepest part of the lungs, what we call the alveoli. These are little air sacs that are the terminal parts of the airways in the lungs. And once they reach the alveoli, they start multiplying. Next slide. So the alveolar macrophages, the immune cells that are already there, they begin to surround and basically engulf or ingest the bacilli. This is the first level of containment. Now, the bacteria, as we know, the TB bacteria is resilient. It has figured out throughout the centuries how to evade the immune system of the host. So it will continue to grow. And the macrophages are attempting now to recruit other help. So within the next 2 to 8 weeks, T cells and B cells, monocytes, neutrophils are also recruited to the area to basically try to stop the multiplication of the bacteria. And so this granuloma, or basically barrier, is formed around the bacteria. Now, as I mentioned before, if the bacteria are contained and not really able to multiply and spread, this is a state that we call latent TB infection. And I'll talk more about these other bullets later, but at this moment, a person is not contagious. They cannot spread the bacteria to anybody else. The bacteria are contained within this shell, and we call this whole thing a granuloma, but it's contained. Now, the interesting thing is there's a lot of sort of laboratory-based research showing that it is a constant push and pull. So as T cells die, as B cells die, as macrophages die, new ones are constantly being recruited to try to maintain this level of containment. So even though we say latent, number one, the bacteria is metabolically active and can basically start multiplying at any time if the conditions are right. And this entire process of a granuloma is quite metabolically active as well. It's not that it's, this layer is forever embedded. The layer is constantly shifting and evolving. And this then gives the TB bacteria many, many opportunities to try to grow and spread. It's just waiting for the right conditions. Next slide. So most bacilli, once this granuloma is formed, most of the bacilli are destroyed or they're kept in check. But again, they're not necessarily completely killed. And so at any time, they can actually enter the bloodstream or spread throughout the body. So if the immune system cannot keep these tuberculosis bacilli under control, they will begin to multiply, spread, and cause disease. And this can happen anywhere in the body. Next slide. So the bacilli that are still alive, once this granuloma shell has been compromised in some way, and that can be because somebody develops cancer, somebody develops HIV or some other immunocompromising condition. Maybe they start taking immunologic agents because they have really bad psoriasis or other dermatologic conditions. Maybe they develop poorly controlled diabetes that creates sort of this immunocompromised state. There are many reasons why this could happen. But once those bacteria are given the opportunity, they will spread. They can spread either through the bloodstream or through lymphatic channels in the body to anywhere throughout the body. We might see TB meningitis, we can see TB of the bone, of the spine, kidneys, anywhere. And so, once that happens, the body's immune system is going to respond, and the person is going to feel unwell and develop relevant symptoms. Next slide. So I know this table has a lot of information. We'll just quickly go through it so you can see the difference between latent TB infection and TB disease. This is a really confusing concept for most of us, because really it's a spectrum. There is a spectrum of states in which the body can be. So if somebody has breathed in the bacteria, but they haven't formed that granuloma, that's one state. Once they've formed the granuloma and the bacteria is not dividing or spreading, that's what we call latent TB infection. But once that granuloma is compromised and the bacteria is dividing and spreading, the person may not be symptomatic yet. So it's sort of a subclinical state that they're in that we may not be able to identify unless we do particular testing. And then once that TB bacteria has gone through the body or localized somewhere and is multiplying and causing disease, that's what we call active TB disease. So it's a spectrum. So how can we really tell the difference? So if somebody has latent TB infection, they have a small amount of the TB bacteria that's in their body. It's alive and it's metabolically active, but it's not multiplying and it's not causing any kind of signs or symptoms. Whereas in the person with TB disease, they have a lot of bacteria now because it is multiplying and it is spreading throughout the body. So the person with LTBI cannot spread TB bacteria to anyone else because it's contained. But once that bacteria is starting to spread, and especially if it's in the lungs, then it can be spread to other people. Persons with latent TB infection, they don't feel sick, whereas a person with TB disease will have symptoms. They will have fever, cough, chills, weight loss, night sweats, or depending on where the TB disease is located, will cause those type of symptoms. So if it's TB of the eye, they may have changes in their vision. If it's TB meningitis, they may develop severe headaches. So it depends on where that TB has sort of set up shop. Now, with latent TB and TB disease, we have some tests for TB infection that show whether someone might have been exposed to TB. Whether that's the tuberculin skin test or the TB blood test that you're going to hear about a little later in the series, either one of those are likely to be positive. But in TB disease, when the person's immune system is overwhelmed and it's busy trying to respond to the TB disease, that test for TB infection may actually be negative. So we're never going to rely on that test to decide whether somebody has TB disease or not. You're going to look at the entire constellation of the risk of exposure, what kind of symptoms they're presenting with, and what is the likelihood that they have TB disease. You're not going to just rely on that test. And similarly with the chest x-ray, in latent TB infection, when we do a chest x-ray, that x-ray is more than likely going to be negative. It's going to look completely normal. But in TB disease, particularly pulmonary TB, that chest x-ray may be abnormal. And I'll show you a couple examples of that a little bit later. But if it's early enough, that chest x-ray may actually look normal. Or if you're immunosuppressed, that chest x-ray may look normal. Now, we do other tests like sputum smears and sputum cultures. Sputum is when we induce someone to cough. We collect that expectorant, whatever they've coughed up. We will do what we call an acid-fast stain to see, just under the microscope, do we see any of the TB bacteria? And then we'll send it for culture. And as most of you know, the culture can take 2 months before we might get a final result back, because TB is a very slow-growing bacteria. So we'll look at those tests for additional information. We may do a CT scan of the relevant area that could be affected. We may have to do MRIs. We may need to do biopsies. There's several other tests that we might do to try to make sure that we're ruling in or out TB disease. And then once we have identified someone having latent TB infection, we really want to treat that person with several, we have several preventative treatment regimens. We want to find one that's ideally shorter course, and really treat that person for their latent TB infection so that we can kill any TB bacteria that might be in the lungs. And then for TB disease, we don't have a choice. We must treat that TB disease. Otherwise, the likelihood of mortality is very high. And with persons with latent TB infection, again, we do not need to isolate them because they cannot transmit that TB. But for persons with active disease, we do need to do the respiratory isolation until we have sufficiently treated the person to the point where they're no longer infectious. Next slide. Okay, so as I mentioned again, there's a clinical spectrum between latent TB infection and active disease. But again, the word latent is a misnomer. The TB bacteria are metabolically active. And actually, there's a lot of discussion in the TB world about whether we should even be calling it latent TB infection. And maybe we should just call it TB infection because it's, it's not really latent per se. So among people with latent TB infection, there is what we believe to be a 10% lifetime risk of developing TB disease, of progressing. And typically that progression is more likely to happen within the first 2 years after your infection. So once you've been exposed, the next 2 years are sort of the highest risk time for progression to TB disease. But again, LTBI or latent TB infection is treatable and TB disease is preventable. So we want to always keep that in mind when we're identifying someone with latent TB infection. Next slide. And as we know, tuberculosis disease is just the tip of the iceberg. The people who are actually presenting with fever, cough, chills, those are, obvious. It's the tip of the iceberg. But below that surface, there are millions of people who are actually infected with the TB bacteria and are at risk for progression to TB disease. And those folks with latent TB infection, we really do want to identify those folks and get them on the preventative treatment. Next slide. So who's at risk for developing TB disease? You will go into more detail in this later on in the summer series, but I'll just briefly mention here that if we don't treat that latent TB infection, 5% of people are going to develop TB disease within the first 1 to 2 years after that exposure and infection. And then another 5% might develop TB disease later on in their life. And I'll just give you as an example, in New York City, among our persons who have developed TB disease, their median time in the US before they break down with TB disease is actually 13 years. So we absolutely see people who will go on to develop TB disease beyond that first 1 to 2 years. But that first 1 to 2 years after they've been exposed is sort of the highest risk. But among people who have a weak immune system for whatever reason, they are at significantly higher risk of progressing to TB disease. And so among someone who has HIV infection, who is not currently being treated, their CD4 count might be low, their risk of developing TB disease is actually 7 to 10% each year. So not a lifetime risk, but truly sort of a yearly risk. And then similarly, people who have diabetes and TB infection, they have about a 30% lifetime risk of developing TB disease. Children less than 5 years of age, I really want to emphasize this one group. Their immune system is not fully developed. They are at significant risk for severe and disseminated TB disease. Any child less than 5 who has latent TB infection absolutely needs to be started on LTBI treatment, and we need to ensure that they complete that treatment because they are at significant risk for developing TB disease. And just as an example, over the last couple of years, we have had a child, a 10-year-old, that actually died of TB disease. So this is not something to be taken lightly. And then certainly people with certain medical conditions, they might be underweight, they might have a need for organ transplantation, they might have sarcoidosis, they might be a smoker. Those folks are also at risk for progression. Next slide. Sure, Anita, I think that's right. I just noticed the time as well. Why don't we go ahead, next slide. Okay, next slide. Okay, so the majority of active TB disease is located in the lungs. 80% of our TB cases are pulmonary. So that's the most common site. Symptoms, as I mentioned, could include a prolonged cough, say 2-3 weeks of a cough. What we typically see is that someone might go to their doctor in that time. They might be prescribed an antibiotic, like let's say a fluoroquinolone, that actually is going to partially treat the TB disease. So symptoms might temporarily improve, but then over time, the symptoms will return because we haven't completely treated the TB disease. And so we might then see fever, a prolonged cough. We might see blood in the sputum, night sweats, a decreased appetite, unintended weight loss. These are all signs and symptoms that are suggestive of TB disease. But as I mentioned, the TB can go anywhere in the body. And so the figure on the right shows you a variety of locations where we've seen a TB disease. And in other countries of the world, we might see that, for example, someone is having trouble getting pregnant. And it's only through the workup that we realize they actually have TB disease of their reproductive system. And that might be the first way that we know that they have TB because it's extra pulmonary. They're not necessarily presenting with that fever and cough. Next slide. So I'll go ahead and skip this slide. Next slide. And next slide. Next slide. What I'll just mention here with the cavitary TB, so this is a photo, obviously, of a chest X-ray, and what we're looking for is that white, fluffy, cloudy appearance. Kind of looks like snow on an X-ray. It can look like a regular pneumonia can look like this as well. And it takes sort of an astute clinician and an astute radiologist to think TB. And in this case, we're seeing obviously TB on both sides of the lungs. There are areas that look like little punched out holes, and that literally is what we call a cavitary lesion. It's actually destruction of the lung, resulting in air-filled spaces or even fluid-filled spaces. And when we see cavitary TB, we have to treat longer than we normally would. Next slide. And next slide. Next slide. Okay, so I'll briefly mention this TB classification system. We don't need to go into it in too much detail because you'll have these slides, but essentially most public health programs use a TB classification system to try to really track and monitor the kind of TB that they're seeing. And this classification system usually includes whether or not there was an exposure, like what is the risk that this person has TB? Do we have a positive test for TB infection that shows us that someone has been exposed to TB? Do we have any clinical findings consistent with TB? And then we sort of classify the person accordingly. So I'll just point your attention to class 2, which is what we call latent TB infection. So we have a positive test for TB infection, but we have no clinical evidence that it's causing disease. So that is what we're going to call class 2 or latent TB infection. Class 3 is TB disease. So we have the positive test for TB infection. We might have an abnormal chest X-ray or other findings that are consistent with TB. And we have a positive culture, or we have a positive smear, sputum smear, something that proves to us that there is TB bacteria there. That's class 3. And then class 5 is where we don't have everything we need yet to make that class 3 determination, but we do have a concern that this is TB disease. And so we're going to call it class 5, and we're going to do the necessary diagnostics to either rule in or rule out TB disease. Next slide. So class 3 or class 5 should be reported to your health department so that the TB staff can be aware that there is somebody who has TB disease or might have TB disease, and they could start to help monitor that person. In certain jurisdictions, class 2 may be reportable to your health department. So it's very important to know your state and local laws and regulations regarding what you need to report. And so, for example, in New York City, we monitor anybody who's been a contact to someone with class 3 disease. And then in New York City, kids less than 5 with latent TB infection are also reportable. And we do case management to try to figure out, have those kids gotten the x-ray they need? Have they started and completed the preventative treatment that they need? Next slide. So I know I presented a lot of information here. I guess my take-home messages for you would be that, remember, TB is a resilient bacteria. It's incredibly smart and able to adapt. But it is preventable and curable. And so we always need to think, test, and treat TB. We need to keep it on our differential when we're seeing somebody with consistent signs and symptoms. And in certain populations, we don't want to minimize a latent TB infection because that bacteria is there, it's metabolically active, and it's just lying in wait, waiting for the opportunity to turn into TB disease. So we really want to encourage the identification and treatment of latent TB infection. Next slide. So I'm going to stop here and say thank you all for sticking with us through this long presentation. I hope that we have a few minutes for question and answer, but certainly Anita will be able to reach me at any time if you have questions that you'd like us to follow up on more individually. Thank you.
Thank you, Dr. Parvez. That was a really good presentation, very informative. And we do have some questions. So I'm going to read you the first question that we have. When someone has TB in the eye, what diagnostic studies are typically completed?
That's a great question. So first and foremost, like if we suspect TB in any capacity, we want to try to identify, first we'll do like as I mentioned, the test for TB infection, but we're not going to rely on that. We're going to do a chest x-ray to see whether you have TB in the lungs that could be communicable to other people. And then for the eye exam, it's going to need to be a good referral to an ophthalmologist for, a dilated eye exam to see. And then there'll be other things that we'll do as far as your vision tests, your test for peripheral vision, color vision, just to determine the potential extent of the involvement, and then to be able to monitor the patient clinically. But, we wouldn't just stop at sort of a basic eye exam because we need to know, is it also in your lungs? Is it anywhere else in the body? So it's going to require a good history, a good review of symptoms, and then a good exam. And it could involve, for example, if someone's also complaining of headaches and other things, then we're going to want to see, is it in the, in the brain and the lining around the brain? So that might require a spinal tap. There's a whole host of things that we might do depending on your signs and symptoms.
Thank you. I do have another question, and that is really a very important point. Any kind of extrapulmonary TB, please check if it's in the lungs. Are there any immune response type symptoms that are experienced during this stage of the granuloma being formed and continuing to contain the bacilla during the first couple of weeks or even years after infection? And would a person with LTBI have some sort of immunosuppression as the body continues to contain these bacillas?
Yes, this is such a fantastic question. And honestly, the studies and the data behind this are fascinating. So I would encourage anybody who's interested in immunology to look into this. But really, it is a daily push and pull between the immune system and the bacteria. And what we're learning is that, we used to think that the granuloma is only there to inhibit and kill and destroy the TB bacteria. And what some people are suspecting now is that the granuloma might be the TB bacteria's way of staying alive, actually. So it's both. The granuloma, in a way, is protecting the bacteria and keeping it alive in this sort of dormant state. But because, you know, immune cells are dying and being replenished and constantly being recruited, you're absolutely right. Like, there can be moments in that time period where maybe some of the immune cells have died, the granuloma wall is a little bit weak, and we're in the process of recruiting new cells, that the bacteria can take advantage of that weakness. And certainly, you know, we talk about stress and diet and, you know, medications we might be taking, or chronic conditions we have that are poorly controlled, or even pregnancy, which can kind of create this somewhat of an immunocompromised state. Any of these situations or conditions can lead to the bacteria then starting to grow. I mean, that's why it's brilliant. So the granuloma is there to, in a way, inhibit it, limit its ability to access oxygen that it might need to start growing. But at the same time, the granuloma is preventing all the immune cells from coming in and completely killing the bacteria. So, you know, the bacteria basically is creating enough of an immune response to contain it, but not to completely kill it. And that's really the fascinating part about a granuloma.
Wow, that is good to know. I have two more questions before we wrap up. I think we can get to them. Is it possible to develop TB disease after treatment for LTBI?
Yes.
So unfortunately, you know, I think the answer is yes. We could treat the bacteria with our known regimens. We have, you know, that success rate, let's say, would be 80 to 90%. We know that the person's going to be, you know, the TB bacteria is going to be killed, and the likelihood is, you know, minimal that they're going to go on to progress. But it's theoretically possible that we didn't kill all of the TB bacteria, that there is still TB bacteria in the body that theoretically could grow in the future. The other thing is that, you know, just like influenza or COVID or any, you know, any other respiratory condition, you could be re-exposed. And so someone could have latent TB infection based on exposure, number one. We adequately treat them, we kill all the TB bacteria, but in the future, they have another exposure and they're at risk again. And so if they have a second exposure, we do need to think about treating that second exposure again.
Or came back positive, that we wouldn't have to treat them again.
Sorry, I think maybe someone needs to mute.
We're gonna have to treat.
Okay.
Sorry, I was on mute. We do have one more question.
Sure.
Before we wrap it up, I think we can get to this one. Are you aware of any false positives for quantiferin gold with some autoimmune conditions such as RA? People on biologics often get an initial and yearly screening for TB due to immunosuppression. So this does make up a fair number of tests we see. If a false positive is suspected, would that be confirmed?
Yeah, you know, I think that this is an important question. I think with any test, it's not going to be 100% specific, 100% sensitive in all cases. And so this is where clinical judgment really comes in. And so when you're seeing that patient, you know that if you put them on an immunologic agent, that if they have TB infection, that is a significant risk for TB disease. And so some of it is looking at the risk factors for that person. So, and you'll certainly talk about this more in the summer series, but for example, if you know that someone's coming from a high endemic country, they have a history of family members with TB, or they have some nebulous history of like, yeah, I had a lung infection once and I had to take some medication for, you know, X number of years. Whatever it is, like if there's anything in that history that makes you concerned that they could have real TB infection, then you're going to err on the side of caution with that patient, but it's going to be the clinical judgment. And so if you have a test that's positive in someone who, you know, has never been out of the country, they don't have any visitors that have been out of the country, they have never been a contact to a case, they don't work in a correctional setting or, you know, et cetera, then, you know, you might think to yourself, okay, is this real? Is this not? But you're about to put them on an immunologic agent. So you need to really use your clinical judgment to figure out, is this someone that I should just go ahead and preventatively treat? We have treatment regimens as short as 4 months, daily rifampin, or 12 weeks of isoniazid and rifapentine regimen. This is relatively short duration. You could theoretically treat them and then kind of eliminate that as a potential in your mind.
Okay, great. Thank you. We are actually at our time at 11 o'clock. So if you do have any additional questions, please send them to GTBI and we will go through them in the beginning of our next session. I believe that's what our idea is to do here today. And our next session is going to be next Friday, same time, on epidemiology. And I'd just like to thank you very much for doing this talk for our series, because I think it's just such a need out there, because we have a lot of new nurses and new healthcare workers. So with that being said, I don't know if Anita or Shweta has anything to add, but I'm just going to say have a great weekend, everybody.
Thanks, everybody. And thank you, Farah. That was an excellent presentation.
Thank you. Thanks for the opportunity. I hope everyone has a wonderful weekend.
Have a great weekend, everybody. See you next week.